Welcome, everyone. Good morning, good afternoon, and good evening. Thank you so much for joining us for this launch of Women Deliver's latest research, the impact of COVID-19 on sexual and reproductive health and rights, youth-led perspectives, and solutions for a gender-equal world. My name is Eglė Janušonytė, and I am a Women Deliver Young Leader, resident doctor in Dermatology, and also the Vice Chair of the Healthcare Constituency for the Partnership for Maternal, Newborn, and Child Health. So just before we begin, I would like to go over some housekeeping items. So firstly, this webinar is being recorded and will be shared after the event. Natakalam will be providing simultaneous interpretation that is available in English, French, and Spanish. So if you just would see, you may click on the interpretation globe icon, which should be at the bottom of your screen, and you can select the language of your choice. As you can also see, this event will also feature international sign language. And as part of our social media amplification, we encourage you to use the hashtag COVID-SRHRYouth. We will also welcome questions for the panelists, so please do list your questions using the Q&A chat function. Please also be mindful of allowing everyone to have a respectful experience when interacting and engaging online. I'm happy to say that we welcome the many adolescents and youth who are joining this webinar. Should you perhaps have any questions or if you need some kind of support, please contact Julia Fan, who is the Senior Manager of the Youth Team at Women Deliver. You can see her contacts in the chat box. If you would be experiencing any technical issues, please contact Darcy Allen de Gracia. Please see her contact details in the chat box as well. And finally, we would like to extend a special appreciation to the Youth Planning Committee, of which I had a great pleasure of being the part of, who conceptualized this event from the very beginning to the end and made it fully youth-led. So I would like to thank Liz Guantai, Barti Kanan, Boris Nachuku, and Isaac Olufadeva. So the COVID-19 pandemic has had a disproportionate impact on girls and women in all their intersecting identities, and has exposed and exacerbated gender inequalities worldwide, critically undermining the progress that was made across every measure of development, including safeguarding sexual and reproductive health and rights. And truly, as a young healthcare professional, I often find myself asking, how can we move forward from this to ensure that the progress made on gender equity and towards realizing SRHR is not lost? So, led and conceptualized by youth events, including Women Deliver Young Leaders, this event is launching Women Deliver's latest research that is examining the effects of the pandemic on access to SRHR services, information, and products in low and middle income countries, with a particular focus on India, Kenya, and Nigeria. And if I may note, the insights of adolescents and youth are quite often absent from such global evidence reviews. So I'm happy to say that this study is one of the first of its kind that is directly highlighting the firsthand experiences and insights of adolescents and youth on the gendered impact of the pandemic on SRHR. So I do hope that you see this event as an opportunity to have this intergenerational, multi-stakeholder discussion about the key findings of this research, highlighting the challenges and barriers that girls and women face in SRHR, and also the research policy recommendations. So for the next 90 minutes, youth advocates, civil society, government, and the private sector will present their perspective on the challenges as well as their commitment to ensuring SRHR in context of pandemic. Just to briefly go over through the format, we will begin with opening remarks that will be followed by the presentation of the research and a vibrant panel discussion. As I've mentioned, we will also have some time for questions and answers that will be followed by closing remarks. So let's begin right away. And it is my absolute pleasure to introduce a fierce SRHR advocate and a dear friend, Ms. Barbara Nyaga, who is the director of the Standing Committee for SRHR and HIV/AIDS from the International Federation of Medical Student Association, to provide the opening remarks. So Barbara, please take it away.
Thank you very much, Eglė. A good morning, afternoon, and evening to all of you. 2020 is a year that the world will soon not forget. With the emergence of COVID-19 as a pandemic, its profound effect was felt in many sectors, and it changed the reality of living in the 21st century. To date, among the most hard-hit sectors was Srhr. For example, as a young healthcare worker, some of the effects that I noticed at the hospital were that the antenatal clinics were closed, and both routine and high-risk pregnancies had suboptimal follow-up. Mothers requested for planned delivery earlier for both cesarean section and induction. There was a request for early discharge because people feared contacting COVID, reduced night admissions, and of course, mothers arrived late in the active phase of labor. And there was an increased request of long-term removal of family planning methods. Women in particularly were disproportionately affected by the pandemic, as there was a reduced access to family planning services. There was an increase in gender-based violence, as well as they were cut off from the essential protection services and social networks. Some were housed with their perpetrators. There was an economic stress that led to transactional sex and exploitations that led to an increased incidences in HIV infections, STIs, social stigma, and unwanted pregnancies. The lockdowns created barriers for the youth as they were unable to access youth-friendly services, comprehensive care clinics, and access to pre-exposure prophylaxis. There were higher rates of maternal mortality rates that were due to the reduced access of safe abortion services, antenatal care, and skilled attendants during delivery were also missing. Homophobia escalated during the pandemic period, and the youth in particularly fell victim to physical and psychological abuse among the LGBTQ community. Reflecting on the above, there is an increased need to involve the youth in tackling the many Srhr gaps that were magnified in this pandemic. As we are the future, the building blocks and foundations of the days to come, hence the significance of our involvement can never be emphasized enough. An astounding example of such meaningful youth participation was this research that was conducted by Women Deliver. It was the first of its kind to center youth insights and experiences and put youth at the forefront and background of the research. It gave focus onto the developing world, which was hard hit by the pandemic, but has very little data to support it. It provides a reference point for future generations to know the aspects of Srhr service delivery that need to be strengthened in disasters. It re-emphasizes the need to prioritize Srhr as an essential healthcare need during pandemics and emergencies. It provides an evidence-based advocacy, which will serve as a roadmap on what pertinent issues need to be laid emphasis in order to achieve universal health coverage. I particularly found this research very applicable because it brought up the many challenges that were faced in Kenya during the pandemic. The critical funds were diverted from women and girls' health to the COVID-19 response. Many county health centers providing family planning services were closed. Healthcare workers were redeployed to quarantine and isolation centers. And of course, there was a challenge in procuring menstrual health products that resorted to girls taking part in transactional sex in order to provide for themselves. This research validated the efforts that we conducted in Srhr locally during the time of the pandemic. And that being said, we are a key as the youth to many solutions that we face in the Srhr. And therefore, we should continue to advocate for budget transparency and accountability by bringing public awareness to Srhr cuts through press releases and conferences, establishing task forces where youth are prioritized, safeguarded, integrated in the pandemic response and recovery efforts by the government. Youth can also volunteer to take part in the provision of services, like in the GBV call centers, rescue teams. They can run mobile-friendly services and reach out and distribute essential Srhr kits along with relief food. And of course, leveraging digital platforms to promote Srhr information and make it widely available to women and girls during the pandemic. Last but not least, youth in the healthcare workforce are best placed to change the attitudes and stigma that comes around the shaming and revolves around the acquisition of the youth-friendly services in the next generation of healthcare providers. By prioritizing the young people's diverse Srhr needs and ensuring that they are at the forefront in identifying effective solutions, policymakers can prevent these harms to young people and strengthen our collective future. Thank you.
Thank you so much, Barbara, for these opening remarks and for highlighting the role of youth in balancing the impact of the COVID-19 on Srhr and for making these points on the youth health workforce. And of course, I would also like to thank you for your leadership with medical students organizations and ensuring awareness on maternal health on national and international level. And now I would like to invite you to buckle up your seatbelts because we are about to take a tour de force, diving into the key findings of this research. And I cannot wait to hear more about youth role in it. So let me introduce our next speaker, who is Ms. Kinza Hassan, Manager at Policy and Advocacy at Women Deliver. Kinza, the floor is yours.
Thank you so much, Eglė, for your kind introduction. As Eglė mentioned, this study explores the impact of the pandemic on sexual and reproductive health and rights, with a specific focus on youth and low and middle income countries, examining country contexts in India, Kenya, and Nigeria. It was one of the first of its kind to highlight the firsthand perspectives of adolescents and youth on the gendered impact of COVID-19 on SRHR. So we explored 3 research questions. At the systems structural level, we explored how the pandemic impacted SRHR-related health systems and supply chains. At the community level, we explored the impact of the pandemic on social norms, discrimination, and stigma in accessing SRHR. And then at the individual level, we explored how the pandemic impacted demand and access to SRHR. So this analysis demonstrates that SRHR is influenced by a complex interplay of individual, household, community, and systemic factors. So there were 4 phases of the study where youth advocates were engaged as co-researchers. The initial phase involved a rapid desk review to narrow the scope of the study, define research questions, and inform the design of data collection tools. This was followed by qualitative data collection to gather rich youth and expert perspectives, entailing in-depth semi-structured interviews with key informants and youth advocates working at the intersections of gender equality, COVID-19, youth, and SRHR. Women Deliver also co-convened a youth-centered validation workshop with youth advocates. This was actually facilitated by 2 Women Deliver young leaders to validate the key findings and to begin that policy recommendation co-creation process. This work was also peer-reviewed by 3 partner organizations working on the subject matter. So the report focuses on 7 key findings and 6 associated policy recommendations. And I will briefly touch on these, but really look forward to the panel to do a deeper dive into each of them. So at the first key finding from the report was that the ripple effects of deprioritizing SRHR were felt globally. Youth advocates interviewed in the study specifically reinforced that reproductive health was sidelined and seen as non-essential to prioritize pandemic response. And so as a result, multiple challenges arose because SRHR was deprioritized. So for example, crucial services like safe abortion were disrupted. And in addition, primary sources for family planning were also shut down due to pandemic restrictions. Additionally, the pandemic placed an additional strain on an already struggling healthcare system as critical funds were diverted from girls and women's health to COVID-19 response and recovery. And so youth advocates in the interviews specifically noted that the pre-existing lack of investment in SRHR, as well as the gaps between policy and implementation, were compounded during the pandemic. And this really exposed the weaknesses of under-resourced healthcare systems. And it was specifically noted in the research and through the interviews that budget advocacy was absolutely crucial to advance SRHR service delivery, with determining factors being both the allocation and the release of funds. So while governments are responsible for providing healthcare to their citizens, the research found many non-state actors like civil society, religious institutions, schools, private sector actors stepping in to provide SRHR services. And so youth advocates really noted that civil society was essential to advocate for SRHR, to deliver services, and to hold governments accountable. And so as a result, the pandemic really exacerbated the government's dependency on non-state actors to fill new but also existing gaps to deliver essential SRHR services. So additionally, the research found that marginalized girls and women were most affected by the pandemic and related policy responses due to pre-existing stigma and discrimination concerning their SRHR. Youth advocates in particular noted that during the pandemic, stigma, discrimination around accessing SRHR prevented adolescents and youth from seeking the services that they need. Evidence actually showed that adolescent girls in particular were impacted because they experienced a loss of control over their decision-making and were denied access to SRHR services. And girls and women living with disabilities were treated poorly and dismissively by healthcare providers, which led them to avoid accessing further care. Additionally, a dangerous inverse relationship emerged. We saw gender-based violence rates increasing while the pandemic was severely limiting GBV's prevention and response services. So youth advocates in the interview specifically noted that GBV increased and put adolescents and youth at risk because of their inability to access protection services. And additionally, marginalized groups, especially girls and women living with disabilities, faced increased risk of GBV due to extended pandemic restrictions. In addition, adolescent girls were at an increased risk because they were pulled out of school, which were seen as safe havens, and thus they couldn't access SRHR services and alternatively faced early marriage. So as a result of the findings from the structural level and the community level, at the individual level, the research found that COVID-19 had a negative impact on SRHR outcomes for girls and women. Youth advocates specifically noted an increase in unintended pregnancies due to difficulties in accessing SRHR services. In particular, youth and adolescents' access to contraception was disrupted because of school closures where essential services are often provided. And the last key finding was that the use of digital technology to access SRHR services and information increased, but it actually left many excluded due to the digital divide. And so youth advocates in the interviews specifically noted that while organizations and models were using digital technology and it was effective, it was inaccessible for hard to reach populations. So based on the key findings, there were 6 policy recommendations that were co-created with youth advocates for stakeholders to take forward to strengthen and uphold SRHR in emergency and non-emergency contexts. So the first policy recommendation, we noted before that the pandemic significantly impacted health systems, which had a disproportionate impact on girls and women's realization of SRHR. And so to this end, the report calls for SRHR to be included as an integral component of universal health coverage. Resilient, integrated, well-funded health systems are going to be critical to ensure that SRHR, the bedrock of gender equality, will be realized for all. Additionally, given that under-resourced health systems were hard hit, the research calls that it's important to ensure adequate and fully protected budgetary allocations for SRHR, along with the release of their funds to achieve the full realization of SRHR. And specifically, civil society and youth-led budget advocacy is critical to ensure that budget allocations are protected and that they are firmly rooted in disaggregated data. And also, while the government holds the ultimate responsibility to uphold SRHR, civil society partners who fill an important role and reach that last mile in SRHR service delivery and advocacy must be supported with increased and maintained political and financial support. So as we noted, GBV increased while the pandemic severely limited GBV services. And so to this end, it will be critical to ensure the financing of comprehensive, integrated, survivor-centered GBV prevention and response services for girls and women in all their intersecting identities. The research also calls to maintain accessible, equitable, appropriate adolescent and youth-friendly SRHR services, particularly in emergency contexts, in order to ensure continued access for those who may be facing multiple barriers. Services must be provided in non-judgmental environments, for example, schools, and many stakeholders like parents, religious institutions, and healthcare workers must be engaged to reduce stigma, especially for young people. And finally, the last policy recommendation, we noted before that while the use of digital technology increased, it left many excluded. And so to this end, the use of digital technologies must be combined with efforts to address the gender digital divide. Digital solutions must provide accurate, comprehensive, youth-friendly, and accessible SRHR knowledge, especially for hard-to-reach and low-income communities. So I thank you all so much for this opportunity for us to share this research with you. I am so excited to hear more from the panelists, and I turn it back to you, Eglė. Thanks.
Thank you, Kinza, for such a comprehensive introduction. It resonated a lot with me. I'm sure it resonates with the SRHR advocates who are attending. So let me now present all our stellar panelists for today's discussion, who I will ask to turn on their cameras when introduced. So let me start with Dr. Jan Askew, who is an advisor for the Africa Regional Office for WHO. Second, I will go to Dr. Bashir, who is working at the Department of Family Health at Ministry of Health for the Government of Kenya. Dr. Bashir.
Good morning, good afternoon. My name is Dr. Bashir, Head of Department of Family Health, Ministry of Health. We are
Hello
Adolescent
and welcome.
Thank you.
Thank you. Next, I would like to welcome Ms. Margaret Bolaji Adegbola, who is founder at the SWAG initiative. Ms. Margaret?
Glad to be here.
Welcome. Next, I would like to welcome Mr. Temitayo Erogbogo, who is a director for MSD at Mothers. Welcome.
Hello, hi everybody, and really nice to be here, and congratulations on the launch of this report.
Great, and last but not least, I would also like to welcome Dr. Dvipa Prasad, who is Chief at the Program and Technical Support at UNFPA. Welcome.
Hi everyone, glad to be here.
And so now, as all our panelists are introduced, we are going to dive right into an initial round robin and further discuss these presented key findings with our panelists. Afterwards, we will have a second round to see how we can challenge the policy recommendations. And then we will be happy to accept your questions at the Q&A part that you may submit anytime during the discussion. You may even submit them now. So without any further ado, let's zoom out a bit and try to get this global perspective. So Dr. Yan, reflecting on the structural and systemic level findings of this research, could you speak to your perspective and work at the WHO on how this ripple effects of deprioritizing SRHR were felt globally and how the health systems that were under-resourced were hit by it? The floor is yours.
Thank you very much indeed, Eglė, and it's very a great honor to be here with you all. As you know and can imagine, working at WHO through the pandemic has been a difficult time, and the data that we've seen in the report really reflect a lot of the experiences that we were hearing from our country offices, from our regional offices, and really influenced the response that was being undertaken globally. As you've heard, the disruptions played out in several ways. They played out not only in terms of supply of services, commodity supply chains were disrupted, information mechanisms were affected, and really importantly, a lot of staff challenges were experienced, staff being reassigned, services being stopped, and staff themselves suffering both illness and death through COVID. We heard also that the demand for these services changed. Less people were able to access services, less people felt comfortable about seeking for services. Many people lost their jobs and so had less income to spend on SRH services. And all of this led to a tremendous reduction in use, at least initially, in the pandemic outbreaks around the world. It's important to bear in mind that the disruption in health services affected SRH services tremendously, but not only SRH services, all health services were affected, and the disruptions lasted and are still lasting, even now several years, more than 2 years into the pandemic. What this meant was that in most countries, there was a huge competition for resources between resources needed for the pandemic response and resources needed for continuing essential services. And also within the discussions and allocations for resources around continuing essential services, big debates about which services should receive which resources. And as we heard, in terms of SRH services, there were some significant declines in availability, reassigning of staff, closing of some services, reducing availability for services. This was especially experienced in low resource settings. And this is because in a low resource settings with limited resources, they're less able to have developed or implement a mitigation strategy, something else that could be offered to try to sustain access to services, because there simply aren't resources to reallocate to alternative strategies. And this forced many choices to be made. And in many situations, unfortunately, the choice was not to sustain SRH services. As many of you will know, and was reported in this analysis, the WHO has carried out a series of pulse surveys over time to understand what's been happening. And we found that amongst all of the services that were disrupted, the most disrupted amongst all of the SRH services were services for adolescents. And the disruptions for services for adolescents have also sustained, unfortunately, prolonged more over time. For example, in the last survey undertaken in December, this last December, 48% of countries were still reporting disruptions to adolescent services, compared with 38% of countries for contraceptive services and 21% of countries for post-abortion care. So adolescents really have, of all the populations using and accessing SRH services, really have and continue to be the most affected by the disruptions. And this is global, but particularly in the low resource settings. It's important to note, and we can talk a bit more about this as we go forward, that many countries did try to introduce what we call mitigation strategies, alternative approaches for making services available. As you heard, digital strategies were really accelerated in many places, and many other self-care interventions were brought in, telemedicines, and also prescriptions of medicines over the internet. Multi-month prescriptions were brought in many places, home-based supplies, outreach services, and integration of services at different points of contact. I'll reflect a bit more on this aspect when we move on to the policy recommendations, but I just wanted to conclude by saying that everything that's in the report certainly reflects the reality that we're experiencing at WHO, and unfortunately is still being sustained in many countries. Thank you.
Thank you, Dr. Jan, and truly thank you for highlighting the adolescent health resources and the digital strategies that I'm sure will be part of the solution in the future. I would like to now move on to our next panelist, Dr. Bashir. Dr. Bashir, could you share the government of Kenya and Ministries of Health perspective and experience on the pandemic impact on SRHR access for girls and women, and particularly on adolescents and youth, continuing with this discussion? And also to shed a light on the impact of the budget allocation on the SRHR services in Kenya. Thank you.
Good afternoon again. I'm happy to be here, and the discussions are really very interesting for me as a first-hand person who is dealing with these issues in the Ministry of Health. I head the Department of Family Health, where we have 4 divisions: nutrition, maternal and reproductive health, adolescent sexual reproductive health is included in that. And we've had quite challenges. I think Barbara's caption of the scenario is quite the reality at that time. But we immediately, after a few months of stagnation, because we closed all health facilities, and the biggest struggle was actually SRH. I mean, mothers wanting to deliver, not having access to any of those services, the curfews at night, where there's no mobility. We had to go out of our way, provide passes for mothers who are going for deliveries, booking mothers in advance for their deliveries, and movement of health workers from essential services to the pandemic. It was a shock to everybody, but by the time we realized our footing 6 months down the line, we've had quite many challenges. And we brought in, we did make use of technology to ensure that we allow the continuation of essential health services, especially LMICs services in the hospitals, and give priority clients time and access to these services. And therefore, we developed the guidelines and disseminated them using the technology, what do you call it, we have the platforms. And use of technology really helped us out. Trainings were happening online. Guidelines were being developed online. It usually take a year or so to develop a guideline, but we've taken a week and 2 weeks to put up guidelines together, disseminate it, and the county is picking up and using them. And therefore, we were the first country actually in this region of Sub-Saharan Africa to develop an SRH, continue essential services amid the pandemic. We realized the pandemic was not going anywhere and the services were suffering. Later, we moved all our COVID services out of the health facilities to allow populations to have access. And therefore, we managed to mitigate some measures. As far as the budgeting is concerned, I must put an underlying fact that the government may not have a direct budget for adolescent sexual reproductive health. It is just within the bigger budget of the Ministry of Health for development services. And one of the things that happens in Kenya is that it's a devolved system where health is a devolved function and the allocation of resources for service delivery generally at the county level. And therefore, it's up to the mandate, of the county to provide, to allocate the resources where they feel is fit. And of course, most of the resources was going to COVID in the counties. Our job at the national level is to provide national guidelines, national policies, and regulations and standards. We've done that quite well, and the counties really, with all the challenges that we've had as a nation, we can say we were maybe blessed to have minimal numbers of deaths of COVID, but it totally disrupted our systems, and we realized how our systems were very weak in terms of resilience and in terms of response to such pandemic. But I believe, looking in hindsight, that we have taken advantage, and it has woken us up to strengthening our systems. Provision of oxygen was not a general thing. It was only in level 5 hospitals. But right now we have in every county an oxygen plant. We have every county a testing place for COVID. We've, in a way, responded, although it was a shocker, and our health systems are much more stronger. As far as the SRH is concerned, it's one of the countries where we flagged out that adolescent pregnancy and GBVs have really skyrocketed. It brought this attention of the policymakers and the government leaders, especially at the political level, to the fact that we have been ignoring or undermining or underestimating the volume of the issues and challenges that we have on these issues. Therefore, there is a multi-sectoral approach where now the chief minister is in charge of a multi-sectoral steering committee, which looks at teen pregnancy, which looks at adolescent health issues. And we have now come up with policies. We are actually developing policies which goes all the way to the grassroots to ensure that this agenda is on the table. We are including it now in the medium-term plans of the government. The government did not used to fund directly, and bring it as a flagship project for adolescent sexual reproductive health. This population is about 24% of our population, and we need to address. Thank you.
Thank you, and we will be eager to hear more in the next Robin part. It was really interesting to hear about the development of these guidelines and role of different institutions. And for now, I would like to welcome our next speaker, who is Dr. Deepa. So Dr. Deepa, could you provide us your perspective on the impact of social norms, stigma, and discrimination on the effect of gender-based violence on girls and women, SRHR, during this pandemic in India? And how did the government and non-state actors, such as UNFPA, respond to this?
Thank you, Eglė. At the outset, let me congratulate the Women Deliver team and the young champions behind getting out this much needed report. I'm sure this piece of research and advocacy will definitely make a dent in actions to address the SRHR needs of young people. When it comes to the impact of SRHR, there are different estimates and there are different numbers that have been given out. But what is evident is that the COVID pandemic imposed lockdown, prevention and management strategies, created barriers and challenges for girls and women to access SRH services. And there is also a rise in GBV, which we've heard from all the speakers. As many of you would know, there was a nationwide lockdown announced on 24th of March, 2020 in India. It was a lockdown for a nation of 1.36 billion population. The transport facilities were suspended, public health facilities converted into COVID-19 treatment centers. There was diversion of healthcare professionals towards emergency response. All of this was on one side. On the other side, there was tremendous fear psychosis, which prevented women and young people from visiting facilities, even when things started normalizing. There was also restriction for women from their family members and spouses, not allowing them to venture out. There was limited access to health, justice, policing, social services, as all of them were concentrating on the COVID response. Within a few days, we also saw that everything went online, and then the big digital divide unfolded. This impacted access to information and services to those who were the most marginalized. As per the Health Management Information System of the Health Ministry of India, during the first wave, there was a considerable dip in services. Not exactly during the first wave, but it was more during the lockdown phase. For example, the antenatal coverage reduced by 39% when compared to the previous years. By the second wave, what we saw is things started improving, though there was a decline compared to the previous years. Similarly, the institutional deliveries decreased between 14% to 23%. But the health system gained resilience, and these figures evened out during the year. While averages do not tell the real story of the girls and women, especially from the marginalized communities, it's for the women from the scheduled caste and scheduled tribe communities in India, persons with disabilities, sex workers, nomadic tribes, migrants, and urban and rural poor who have been disproportionately affected. There was a surge in the incidence of violence against women and girls, and all of us know this was one of the major factors as being at home with abusive partners. There were also reports of violence and verbal abuse of women health workers, especially the nursing staff and the frontline functionaries, by families who were overwhelmed, and those women form 70% of the health workforce. India also saw a big return migration of about, some estimates say it's about 12.3 million migrant workers returned home from urban areas, and many of them were also women among them. We also heard how the school closures impacted young people, and it's the same even in India. Many of the services which are delivered through the schools, whether it is menstrual hygiene products, midday meals, nutrition supplements, all of that came to a halt. Those that were severely affected were also adolescents with disabilities who were going into the special schools. Those were also shut. Beyond the schools, we also saw closure of the adolescent-friendly clinics, which are functional in many health facilities, and also the counselors who were engaged there were now diverted to provide COVID-19 response support. In terms of the response, the Ministry of Health started responding to the situation with a series of guidelines and circulars, and the initial attention was only on ensuring safe delivery, tracking of women closer to the expected dates of delivery, and also ensuring that they have the transportation services and support. All the other SRH services came to a halt, which the previous speakers have also spoken about. Those worst affected were access to safe abortion, STI and HIV services, etc. What was also noted was that there was a lag of about 20 days to a month for the ministry to release these circulars from the lockdown. So for about a month, there was no clarity on what the services could be about. And the first circular came in 14th of April 2020, which talked about essential health services during the COVID-19 outbreak. What we also saw is that many states were grappling with implementation of these guidelines and in resuming services. There was also a lot of fear among the service providers. Young people were the hardest hit, especially those with multiple intersectional vulnerabilities. For example, those with say alternate sexual orientation and gender identities, young people with disabilities, etc. UNFP and many other agencies, those who worked in the space of SRH, the major challenge was to advocate and to support the states and districts to ensure resumption of SRH services and to bring it back to the pre-pandemic levels. While advocacy.
Yes, thank you. And my apologies, I do have to keep with the time. Sure. But thank you for such a comprehensive review. And for now, I would like to move forward to our next speaker, who is Ms. Balaji. And Ms. Balaji, I would like to ask you, the key findings note that the non-state actors stepped up to fill gaps. And I wonder, how do the non-state actors, such as your own initiative, respond to fill these gaps to safeguard SNHR in Nigeria? And could you perhaps elaborate on some examples for the use of digital technology, as technology was raised many times in this discussion? Please take it away.
Thank you so much, Eglė, for your question, and congratulations to the team for such wonderful research. I could really, literally relate with the key findings as well as the policy recommendation. And just to your question, so at the wake of COVID, we all were just struggling to be alive. And we realized that prior to COVID, we had different platforms where we were reaching out to adolescents and young people to be able to have adequate and accurate information on sexual and reproductive health, particularly family planning. And just few months down, actually few weeks, and the fact that people were at home, there was lockdown, then there were a lot of people using their phones. And I know Zoom really came on board, but not everybody could even maneuver the technicalities. Again, you need a larger bandwidth, and even you have to pay for data to be able to go. WhatsApp was one platform that we recognized that a lot of young people were talking about the news of death, the updates, and we decided to then ask, how are you doing? What about your sexual and reproductive health? And that was when it really hit us that despite that there was pandemic, it didn't mean that young people stopped having sex. It didn't mean that young people were not experiencing gender-based violence. And in fact, we had a lot of responses somewhere where it really shows that there were also, while there were so much information, even on sexual and reproductive health and rights, this information where there were a lot of myths and misconceptions. So someone even said something like, oh, so we have to rely on the withdrawal method. We know this is not effective, but it wasn't just that. People saying we use salt and water, overdose of anti-malaria, just to be able to prevent pregnancy. We knew there was trouble. So what we did as an organization was to even have more people join the WhatsApp group and then disseminate frequently ask questions and answers, of course, so that they can get adequate and accurate information. But it didn't stop at that, because young people also needed services. And it was at that point that we needed to refer them to organizations, majorly international organizations, who were offering services confidential, because that was also important for young people. Remember, at this point, they were at home. There were just a lot of restriction, not just the COVID, but a whole lot of things were also happening. And for us, it was really very an opportunity to leverage on technology, because even for some persons who ordinarily do not use phones, schools were beginning to introduce e-classes. So parents had to get phones for their kids. So even at some rural communities, and I hope to still touch on the fact that as soon as the restriction was lifted, we had to set it back into the community, because as much as technology was working, we know that a lot of young people, adolescent girls, young women were still marginalized, and they weren't getting the information that we were providing, as well as the services. So of course, obeying the COVID-19 protocols and all of that, we had to set into the community, particularly internally displaced persons camp, to be able to talk about this issue, refer them for services. but it just goes a long way in saying how much role youth-led organizations, civil society organizations play when it comes to disseminating adequate and accurate information. The one very important thing was also we had people coming to say, you're used to disseminating social and behavioral change communication material, include COVID-19 information. So that integration was also an opportunity to be able to take SRHR information to the community, to even larger audience, because now people want to know exactly what to do about COVID. It was something we never experienced. So it was really an opportunity to be able to integrate all of these messages together.
Thank you so much. And now, just before we move on to the next speaker, I would like to make a note to all the panelists, and actually also including myself, just to try to speak somewhat faster, because our interpreters are having a hard time. We have so many brilliant ideas, but we do have to speak slower. So for the next speaker, I would like to invite Mr. Tayo. So from the perspective of your work, what does the impact of the pandemic on girls and SRHR look like, and what have been the global implications?
Thank you very much for the question, and again, it's a great pleasure to be here. Perhaps just say from a context point of view, our organization MSD for Mothers, which is basically the philanthropic initiative by MSD, otherwise known as Merck and Co in the US and Canada. It's a global initiative to respond to the maternal health crisis that we have across the globe, which impacts, obviously, as many online would know, a lot of low and middle income countries. And when the pandemic happened, the first thing we did was to try and reach out to our partners across the globe to try and understand how it was impacting them in terms of the services that they were trying to deliver, as well as understanding also how it was impacting the users and the clients that they were serving. And that provided us with a very good foundation of information in terms of thinking of how we can most effectively respond as an organization, but also to try and see, okay, well, get a better understanding of this situation from a maternal health perspective primarily, but more broadly in terms of our SRHR. And one of the things that it showed, well, very clearly, as other speaker has said, is that services were massively disrupted. I don't need to tell anyone online about that. But behind all those figures that were reported, for example, in Nigeria, we know that ANC dropped by 50%, delivery hospital facilities really dropped nearly down to, again, not down to zero, in a country where we know there was challenges already in terms of people delivering at the facility. Similar situation, Dr. Bashir was saying earlier on, in terms of situation in Kenya, in India. So there was fundamental disruption, but behind all that were actual human experiences, when we often forget that. And what we're seeing online through some of the work that we also did, and aligns very much with the findings of the report, that the individual impact was catastrophic in some instances. So we have cases of women that were delivered outside the facility because they couldn't get into the facility. Margaret touched on lack of information that was out there. That was really widespread, especially at the beginning of the pandemic, where people didn't understand how this impacted them in terms of their health primarily, but also going on in terms of, okay, how do I then access services? Or should I be accessing services? Do I just stay at home? All these are what we see as basic information. But what this speaks to, and I think was touched on by Dr. Janušonytė earlier on, is how do we strategically respond and embed this in pandemic response right from the start? Because when COVID happened, how to say basically we couldn't, I'd imagine that basically people will still need services in terms of being delivering hospitals, that people still need access to modern contraception, the people still need access to vaccine, we still had to have ANC. So we knew all these things were going to happen. So how do we put this at the front of mind versus what happened during the initial phase of the pandemic, and we're still recovering from in many instances. So that basically, you know, when this happens, something like this happens again, you know, we actually have a system that is viable in terms of being able to respond appropriately. And I think to that point, one of the things that we saw, as Margaret was also speaking to, is that we need to think about from a multi-stakeholder response within our system to build more resilience. Otherwise, what we saw from government is that basically, not to no fault of their own, with the best intention, they didn't necessarily have the capacity to respond or the expertise to respond across the board in every instances. And also government come from different perspectives in terms of their expertise. So from communication point of view, for example, the ability to respond across the board in terms of every single need of every population group was just not there. So how do we actually sort of make sure that basically we bake this in, not just from a pandemic response point of view, but as we look forward in terms of how we build more resilient health systems, more responsive health systems, what role do we all play in that? I think that's where we landed as a result of the insights we got from our partners, and what we saw from sort of like the global, the data that was available globally as well. So I'll stop there.
Thank you so much, and thank you not only for your interesting perspective, but also for intertwining the points from different speakers. And I do think that now, after this round, we have quite a good perspective of this context. So with this, I think some of you could be thinking, how exactly does this translate? We see that it's relevant, but how does all of this translate into some policy action? And how do we take this to full scale? So let's start another round. And I have a question for Dr. Ian. So the research recommends that in order to safeguard SRHR, it should be a central component of the universal health coverage. So could you elaborate on this? Do you perhaps have any recommendations?
Thank you, Eglė, very much for that question. Certainly, as we're seeing over the last year or so, this experience has been a real wake-up call to governments. And we're really hoping at the WHO and elsewhere that this experience is used as an opportunity to really strengthen health systems, to make them much better than they were before, but also to make sure they're much fairer than before, to reduce the inequities that were being generated. This is not the only pandemic we've had in recent years. We've had Ebola, Zika, SARS, and we will have more coming, but we've got to be ready for them. But also between pandemics, so to speak, we need a better, stronger health systems. And one area that we're really trying to promote is to learn the lessons from the new strategies that were brought in primarily by the civil society and NGOs, so that we not only have the existing strategies for promoting and providing sexual and reproductive health services, but we have a wider range, we're bringing in the new approaches that were being developed and rapidly brought in during the pandemic, so that we can add these to the existing ones. So in effect, we have 1 + 1 is 3. We get a much better, stronger health system by building on what was there before and strengthening it by expanding with the many new and very innovative approaches that worked in many situations during the pandemic. And how do we sustain those? Secondly, even before the pandemic, there would be a lot of calls to try to really make sure that sexual and reproductive health services are fully included in national commitments to comprehensive universal health coverage. They're included in commitments, in plans, budgets, financing mechanisms. And not only included, but the inclusion is based on the principles of leaving no one behind, on the adherence to basic human rights, and on efforts to make sure that gender equality is part of the ultimate goal. Many of these commitments now exist, but pragmatically and operationally, what does this mean? How do these commitments need to be turned into making services available, accessible, affordable, quality, and of course, safe? Overarching approach that certainly from WHO and others that we're promoting is to try to encourage a shift in the paradigm from focusing on service delivery of each of these services to a much stronger health systems approach, that we look to strengthening the health systems rather than trying to build in the capacity of the health system to deliver individual services. Strategically, national universal health coverage strategies are being developed. And so from the perspective of civil society, it's important to be involved in those discussions about what are included in the essential health service packages, and more importantly, what services are included in the health benefits plans that countries are implementing, so that the financing for these services are integral to national commitments. Linked to this, it's important that a lot of the health financing mechanisms that were developed and have been developed over the last few years, those that have proven effective and efficient and equitable, sustain these, expand them. And here there's a large role for the private sector, both for-profit and non-profit, as we move forward. And for this audience in particular, the voice of young adolescents and young people is absolutely critical to ensure that this, as a population, if you like, be prioritized in the efforts to maximize coverage of these services. So it's not enough just to argue for inclusion of services in the essential health services packages, but to make sure that young people are prioritized as among the populations. And consequently, the interventions developed are really tailored to the needs of adolescents. So I think a lot of the roles for civil society and youth movements are to continue to build on the increased visibility and recognized impact that's been created by them during the pandemic. And I think Bolaji's example is a very good one to show that I think the value of the civil society sector is now much more appreciated than it was before. Get yourselves recognized and involved as key stakeholders in national processes for developing essential health service packages, health benefit packages. Sustain and continue expand lobbying parliamentarians to include sexual and reproductive health services, all of those services in the health benefit packages. Also, to the extent that is possible, be involved and generate evidence which can be used to justify why these services should be involved. It's really important to have concrete evidence, not only of the economics, but also the health benefits and the rationale from a rights perspective as why these services should be involved in these essential health service packages. And finally, why, when generating this evidence and communicating it, really make the point about this is what people want and this is how people want to receive these services. I think those messages are critically important as well. So hopefully that will generate a bit of discussion, and I hand back to you, Eglė, for the next question. Thank you.
Thank you. I am so sure that this is going to generate discussion. Thank you for these important notes. And thank you for being an ally for meaningful youth participation. It means a lot for the young people attending here, I'm sure. And with this, I would like to move on to our next speaker and welcome back Dr. Bashir. So Dr. Bashir, I would like to ask you, in your opinion, how can the government safeguard Srhr? And could you perhaps elaborate on how adequate budgetary allocations could drive for the full realization of sexual and reproductive health and rights?
Thank you for that question. I must underline that there is no identified specific budget for adolescent SRH. It's an agenda that is just part of the RMNCH. And we have investment framework, investment cases for RMNCH in totality. Out of the RMNCH, A is the adolescent health. And it's just now that we realized with the COVID pandemic that we need to really allocate resources directly to this. And it requires a lot of advocacy at both levels of government. Hopefully the policy that we're coming up with on SRH is going to expose a lot of issues and a lot of contribution from the community level for us to have a proper advocacy in place, including the youths, actually, led by the youths, not including the youths, so that when the budget is read, one of the items that is supposed to be looked at is a budget for adolescent health. We are far from there, I must admit. We are far from there, I must admit that. And It's just now that we are coming into the medium-term plans. Even then, it has not yet been approved. We just put a case that this is an agenda that requires direct funding for a country that is already struggling to own and commit to 100% commodity security for HIV, AIDS, malaria, TB basics. It's maybe a tall order to have a full budget for SRH, but for it to appear in the budget line and have a vote head is one step ahead, and then you can continue advocating for increase. And this has to happen at both levels of government because service delivery is at county level. At the national level, it's just issues of policy and regulations and standards, which we can allocate little resources. But the real thing has to happen, whether it is through conditional or unconditional cash transfers to the counties for them to allocate and ring fence it at that level. So we've just begun the journey, but we are far and there's a lot that can be done. And the youth-led advocacy is the best strategy to employ. Thank you.
Thank you so much. And again, thank you for your support for young people. Perhaps I am biased, but I think it is much appreciated. I would like now to move on to our next speaker and welcome back Dr. Prasad. I would like to ask you if you perhaps could reflect on how does the GBV prevention and response look like, why this should be a part of essential SRHR services, and how these services, SRHR services in general, can be friendly to youth and adolescents. What are your thoughts?
Thank you, Eglė. First, let me throw light on what's the magnitude of gender-based violence in India. In India, as per the latest national survey, 1 in 3 married women between the ages of 18 and 49 years have experienced violence from their spouse. And there's no doubt the pandemic has exacerbated the situation. In a vast country such as India, the efforts to address GBV varies from state to state. And an actual realization of a multi-sectoral coordinated prevention and response strategy to GBV has been quite challenging. For the prevention, there needs to be a concerted effort to change the negative social and gender norms, which can happen if there is a mass movement to change the way women and girls are valued and treated. For this, platforms at the grassroots and community-based structures, such as women's collectives, local self-governments, and community-based organizations need to be roped in, and they need to work closely with the frontline functionaries of health and social development sectors. We need to engage with key stakeholders. One of them is also the faith-based organizations for value-based dialogues, and also with community influencers. Within all these interventions, working with men and boys need to be the core. Men and boys at home, in the neighborhood, in the community, at schools, workplaces, public spaces, and social media. We've seen several programs in India which target women and girls, but it's high time that we target men and boys. An effective and long-term intervention would also be to work with the education system. How do we influence minds during their formative years? Now, coming to the response side, for services to be accessible, available, effective, gender-based violence and gender-based violence response and adolescent-friendly services should be integrated into all levels of healthcare provision. And this needs to be positioned within the universal healthcare package, which Ayan mentioned. In most countries, especially the lower middle income countries and lower income countries, what we see is that many of these programs are implemented as vertical programs, maternal health, family planning, HIV, not a comprehensive package. In India, what we're seeing is we have this universal health coverage under which 150,000 primary health centers are going to be upgraded as health and wellness centers with a defined set of services. While components of SRH are part of the service package, we still see GBV and attention to the needs of young people are not very prominent. Therefore, what can work is an integrated package of comprehensive SRHR services through a continuum of care approach, from community for prevention to the frontline workers at the primary, secondary, and tertiary care, which is very crucial. Now, if we look at what comprises SRHR and how governments look into it and how it's adopted, As per the latest Guttmacher-Lancet Commission, it comprises of 9 services, within which one of the most important is also detecting and preventing sexual and gender-based violence. This approach should be adopted within policies and programs so that women and girls and adolescents have universal access to SRHR, which includes GBV. We also need to have trained and sensitive providers who provide non-judgmental, survivor-centered care. Providers who recognize specific needs of neglected groups such as adolescent girls, sex workers, and persons with disabilities. All of this should go into the pre-service and in-service training. What we currently see is ad hoc trainings targeting a few healthcare providers, but we need to bring this into pre-service and in-service training so that they provide services at all times, whether normal times or during a pandemic or a humanitarian situation. We need to have them built into the nursing and medical curricula. So a whole of society approach targeting the healthcare system will definitely have a result on this. I'll stop here. Thank you.
Thank you so much for this highlight of the many different players needed to move forward these efforts. And with this, let's move to our next speaker, and I'm again welcoming back Ms. Balaji. And Ms. Balaji, I would like to ask you, what do you think is needed to support civil society when it comes to the pandemic response? And you've also talked about technology, and I am wondering, how can we close this gap on the gender digital divide to ensure that girls and women are accessing these available solutions? The floor is yours.
Thank you so much for your question. And again, it's important, and okay, maybe to start with the fact that I acknowledge and also say thank you to all of the speakers that acknowledge the role of youth-led organization, young people themselves. And for us, when we talk about, we're not just talking about tokenism, we're looking at meaningful youth participation where young people are able to design this program, they're able to implement it, monitor and evaluate it. And we know this is not cheap. So there is need for political support. There's need for financial support to be able to achieve this. And let's even start, and while it's important to say invest in youth-led civil society organization or youth-focused youth organization, it's also important that we begin to, and I always say this, charity begins at home. So the government needs to start by taking that step. We looked at Kenya, and if by today we're still not sure if we have a budget line, specific budget line that speaks to adolescent and youth sexual and reproductive health. Thankfully, in some states, Lagos State in Nigeria, for example, has a budget line. Again, it's another different ball game to talk about the release of this budget, the appropriation of this budget, and all of that. But all of this needs to be in place for civil society organization to be able to do the work that they know how to do well. Another important thing is also that we have very wonderful policy, and I'm speaking with regards to Nigeria. 2021, that was last year, we launched a revised national policy on adolescent health and development. And looking at adolescent health, sexual and reproductive, it's a multi-sectoral issue. So it's not just domicile. While yes, it's been led, the Secretariat, it's majorly the Federal Ministry of Health. It's involved Women Affairs, Youth and Sport, and several other ministry departments and agencies. So we need to see how best to coordinate this, and each ministry, departments, and agency are really taking their roles to be able to implement what is expected. Also, it's important that we see young people, again, move away from seeing them as beneficiaries, but as partners. So in developing this laudable project, because most times we think this is what works for them, it's important that we're looking really at ensuring that our primary healthcare centers that are closer to the people in cases when they don't have access to technology, they're youth-friendly, and I mean youth-friendly indeed. In Nigeria, again, we have the minimum service package standard that is expected of our facilities to ensure that we tick them and say, yes, they are youth-friendly, compliant. But how many of those facilities, because even at the wake of the pandemic, not maybe 2 months into it, I just had a baby and then had to put a call through for a family planning service. And part of the question that was, it's also parity. How many do you have? Oh, if we have stock out, it means you can wait. After all, we have people with more children. They probably need it more than you do. This shouldn't be, because we know that it's young people's rights. So regardless of your sex, and I think one important thing that we always need to acknowledge as programmers, as funders, as government, it's the fact that young people are not homogeneous, the diversity of young people. And that's why when we talk about bridging the technology gap, when we talk about ensuring the gender gap, we're also using that lens to ensure that we're reaching young people in rural community, in urban community, young people with disability, with HIV, with different sexual orientation, and what have you. So there's so much to be done, but we need to intentionally and strategically invest in ensuring that young people have access to sexual and reproductive health and rights. Thank you.
Thank you so much for this great intervention. And let's move on to our last speaker for this round. So Mr. Tayo, I would like to welcome you back. And I would like to ask you, because while we do know that the governments hold this primary responsibility to ensure SRHR for everyone, could you explain, you actually touched about it a little bit before, but what is the importance of the multi-stakeholder partnerships in this context?
Thanks very much for the question. And I think the role is critical. I think that the starting point is actually, it's all our responsibility. If we start with that premise and understanding that basically while government has a mandate in terms of delivery, the how, I think, brings us all in to around the table. And I think Dr. Askew spoke to this earlier on. Specifically, the private sector has a significant role to play in this. So you heard from Margaret in terms of the way civil society has been able to respond to some of the gaps, and certainly in terms of the ongoing advocacy as well. But in terms of some of the, so like, one around the issues around the delivery of service, the issue around funding, and the way in which actually we can reimagine building a more resilient, sustainable health system. I think the private sector has a significant role to play in that. If we look at the way in which young people are currently actually accessing services, a lot of the providers that they go to are local private providers in settings like Nigeria, where Margaret was speaking from. I also know in India, it's very much the same thing. In Kenya, it's very much the same thing. So I think there's an opportunity here when we actually think strategically about, given the capacity that government has and the gaps that exist, the expertise the private sector has, whether it's in terms of information, whether it's in terms of commodities, service delivery, being able to actually contribute to or complement government's efforts so that we can augment the capacity within all our geographies. I think the private sector is already doing a lot, but what tends to happen is that they exist outside a wider strategic framework, which incorporates their capacity. And when we start thinking like that, we can make massive difference in terms of economies of scale, in terms of purchasing power, in terms of thinking about ways in which we can actually reach more people. How to sort of like make sure that in different geographies where people feel as if they don't have the opportunity to be able to pay out of pocket for services, and they shouldn't be paying out of pocket for services, we can think of ways in which government can perhaps contract local private providers to provide services. So there are a number of different ways, but I want to point to some work that WHO is actually doing in relation to this. That was partly certainly accelerated, but partly driven by the pandemic, which is the Country Connect on private sector in health. And this is an effort to really think about the resources, the tools, the guidance that basically can be put together in supporting countries to leverage the capacity of the private sector. And we've been very instrumental in working with the WHO team around this, because we really believe that with the best will in the world, government just doesn't have the capacity just by itself to do all that's required. And we also need to think differently, as Dr. Bashir was saying earlier on, about how it is that we actually think about a health system. It's not just enough about putting more money into the same system, but we have to reimagine our health system. So, for example, in a place again like Nigeria, for a lot of young people, it's not that the doctor that they necessarily go to as the first point of call for service, but to the community pharmacist or to the pharmacist. How do we incorporate them into the health system in a meaningful way, where they understand their role, both in terms of what services they can provide? How do we accredit them to make sure that basically they're providing quality? And then how do we make sure that basically they have a referral pathway to make sure that basically people can be directed to wherever it is that they can access services? And this is not theory. I mean, this is work that we've seen already happening. So some of the work that we've supported in collaboration with Bill and Melinda Gates Foundation, called Integrate E, is doing exactly that, is working to incorporate community pharmacists within the health system to be able to provide a wider array of family planning services, and also act as that conduit and that bridge towards introducing people to wider care. So I think there's a massive role that basically private sector can play in this space.
Thank you. I do agree, and I do hope that this perspective will resonate with those from the private sector who are present today, as this gives much food for thought. And as we are now done with our second round, we will transition into the Q&A. Clearly, we see that there is potential to transform these effects into a rare opportunity for more systematic change in the SRHR. But just before we go into the questions, I would first like to pass the virtual microphone to Virginia Osana from Women Enabled International, as a brief intervention was requested on the impact of COVID-19 in realizing SRHR for people living with disabilities. So Virginia, over to you.
Thank you so much, Eglė, and thank you so much to all of the panelists. I have learned so much already from all of your interventions. As Eglė said, Women Enabled requested an intervention to highlight the impact of the COVID-19 pandemic on people with disabilities. Just to give a bit of context, there are between 180 million and 220 million young people living with disabilities worldwide. And young people with disabilities were already facing barriers accessing SRHR services for a variety of reasons, including, for example, the stereotype that we're either asexual or hypersexual, the belief that we might not be able to engage in romantic relationships, the fact that service providers do not have training on disability, and the fact that facilities are most oftentimes inaccessible for people with disabilities. And during the pandemic, these barriers only heightened, and Women Enabled, together with UNFPA, worked on a study that focused on this impact, and it coincided with some of your findings from the study of Women Deliver. So, for instance, one of the most significant issues where we were impacted was the access to SRHR, because during the lockdown measures, for example, people who needed sign language interpretation were no longer able to go into appointment with their interpreters, or people who needed assistance were no longer able to go into appointments with their assistants. And so there was a high impact for people with disabilities, and particularly for people from the deaf community. As also you pointed in your study, there was also a heightened risk of facing gender-based violence. And also we noted that there was a more difficulty to access basic needs during this time. So we also wanted to highlight that one of the policies that some of the policies that can be taken is to take a twin track approach to both the response to COVID-19 pandemic and the provision of sexual and reproductive health and rights services. Also, people with disabilities should always be included in policy, in prevention, response, and also in the building back from emergencies and crises. So I guess I know that I have very little time. So I guess what I'm trying to say, to be super brief and to put it in a nutshell, is that people with disabilities, we have also been impacted, and to build back better for all as we're still going through the pandemic, but we're looking into the future with a hope to get over it soon. In those efforts, we need to include people with disabilities as well. Thank you so much.
And thank you for bringing to spotlight this very important topic and very important call. Thank you. So now we will be moving to the questions part, but as we are running out of time to some extent, I will challenge the speakers and will ask them to try to be as short as possible in their answers, so really concise, and to try to answer in about 1 minute. So let's dwell right away. And the first question is for Dr. Ian. So the question from the audience is if you could speak about some of the useful tools and guidelines that WHO might have to ensure safeguarding SRHR is not forgotten in conversations around the pandemic preparedness.
Thank you for the question. Early in the pandemic, we put together a very comprehensive set of recommendations which went through service by service, what countries could do based on the best evidence that we had at the time to sustain the services, what alternatives could they look at? And then we also included in there some suggestions for transitioning eventually out of the pandemic, which we're starting to get to see in some countries. That guidance has been available, it's online, and it's been used by many, many countries. For this audience in particular, we worked very closely with UNFPA, and we jointly put out a guidance specifically for the issue of SRH services in pandemic situations. It's called Not on Pause, and it's an excellent document which UNFPA has disseminated widely. So yes, the guidelines are available, and the fact that they've been used widely, I think, suggests that they have been useful. Thank you.
Thank you so much for this concise and informative response. Next question from the audience is for Dr. Bashir. It is about the guidelines that were discussed in the first round. And the question is, what advice do you have for other governments who want to work on similar projects for the commitments that are matched with action and accountability? You have 1 minute.
Thank you. The process of policy formulation is very difficult, and it has to include people at the grassroots level. It's not just sitting in a boardroom and dictating a guideline. So the youths and the caretakers of the youths and the community at the population level are the ones to dictate. are the ones to bring in their input, and government has to go with the demands of the people and their rights. So this will bring all other stakeholders on board. The church, which has their own issues with adolescent sexual reproductive health, and the CSOs, the pros and the anti-choices, all of them to be incorporated so that it's much more consultative. And above all are the people whose life is being managed in this agenda, that is the youth and adolescent sexual reproductive health. So we've learned a lot. We've started with at the boardroom level, but we've now gone to the grassroots. We are listening. We are listening to the youths. We are listening to the people who have suffered, the survivors of these issues, and the parents of these issues, and the policymakers and the leaders at the grassroots level and at the national level. So with that, it becomes a comprehensive.
We are a bit restrained by time, but thank you so much for your answer. And the next question goes to Margaret. And the question is, how did you ensure confidentiality while using WhatsApp as a digital tool for SRHR information?
Yeah, Thank you. Good question. Again, we were limited because it looked like the best platform we could use at that point. So while we had generalized messages, we also made it very clear for people who would like to be spoken with or chatted individually to reach out. And also on our Facebook platforms, on Instagram, you can actually go to the direct message and just send a message so that we are reaching you, and then we would make proper referral if you need services and what have you. So that was how much we could go. But we also recognize the fact that some even had to use their parent phone to access this information. So I wouldn't say 100%, we eliminated that, but we tried as much as we to make it very clear to them that it's possible that you can speak to someone who is non-judgmental and will be ready to answer you. Thank you.
And thank you so much. Let's move to next question for Dr. Deepa. So you have talked about an impact on marginalized groups, and we had a floor intervention talking about the challenge of people living with disabilities. So we are, an attendee was wondering if there are any special measures put by UNFPA to address these specific challenges for marginalized groups. Thank you.
Thanks, Eglė. Good question. So what we are doing essentially is working with the healthcare system to ensure services are reaching out to the most marginalized. So we are currently engaging or working closely with organizations working with persons with disabilities to see that young people, especially those going into special schools, have access to information and services for SRHR. So the basic way that we work is to strengthen health system, because UNFPA cannot be working across the country to help them, but in terms of the policies, the program design, a lot of advocacy, bringing in data and evidences on where investments should be and how it could reach the most marginalized. That's how we've been working on, and also engaging with agencies and organizations who work with persons with disabilities with special focus on young people. That's something which we've been concentrating on. Thank you.
Thank you so much. And the last question for this round is for Mr. Tayo. So the question that we received is, well, at the end of the day, the private sector is profit driven. So how can we address concerns that it is the role of the government to provide essential health services to ensure that marginalized groups are not forgotten? What are your thoughts?
Sure. So when people think about the private sector and they think the private sector is just about being profit driven, the starting point actually is more around sustainability. For any business to be profitable, you need to be sustainable. You can't just, at least, for the long term, if you want to invest in the healthcare arena, you have to be sustainable. And for you to be sustainable, you need to be providing value to the patients, to your clients. And from that perspective, I think that's the starting point in which we need to look at this. And then the other point is then, how then does government incorporate and govern the entire health system to make sure that basically the private sector understands its role within that ecosystem, is provided with guidance in terms of what is expected of it, and and how best issues around financing can be addressed. Because even in terms of financing, the private sector has a major role to play. So when you look at health insurance, for example, understanding the fact that basically, again, government doesn't have the full capacity to be able to pay for everything. I think one of the ways in which we can ensure more equitable access for people is ensuring that basically people can actually pay for services, or they have access to services. And one big aspect of that is making sure that they don't pay out of pocket, but we have greater access to health insurance schemes. And there's a lot going on in this space in terms of health, low-cost health insurance schemes that provide an array of services, or access to real services. And those are, so when I said earlier on about how do we strategically look at this, I think to the work that the Country Connect on private sector in health is doing is looking throughout the whole health ecosystem and thinking, where can private sector play a role? And then from government point of view, in terms of, how do we ensure that basically, one, if we want to incorporate this, we do it in a way that is equitable. that is in line with our principle around, what is fair and good in the interest of the patients and the wider public. So
thank you for this answer.
Thank you.
And sorry for the time constraints again.
Okay.
And just to finish, I would like to say what a blast this great event was, in my opinion. And just to close off, last but certainly not least, I would like to invite Dr. Khan, who is the president and the CEO of Women Deliver, for her closing remarks and reflections. The floor is yours.
Thank you, Eglė, and thank you everybody for listening to the event. I have the enviable and the unenviable task. The enviable task being to thank everybody who is involved in this on behalf of Women Deliver. So Eglė, you, the other speakers and panelists, Barbara, Ian, Deepa, Tayo, Margaret, and of course Dr. Bashir, for your for the effort, time and effort you put in, and for bringing your expertise and knowledge to this panel. Thank you so much for that. And then, of course, the Women Deliver Young Leaders Planning Committee. They have been the drivers of this research from the start. They've decided on and given input into the conceptualization and the execution, from the format to the questions, to helping to, of course, moderate the panel and make it really what it is. So again, Eglė, Liz, Parthi, Boris, and Isaac, thank you so much for all the energy and efforts you brought into this, and I hope that this panel made you proud and made you believe in the impact that can be achieved through efforts like this. The unenviable task is, of course, to try to do a 1-minute recap of all this rich and amazing conversation that we've been having over the past little while, and I'll try to keep it very high level and very, very quick given the time. What I heard was 4 things. One, and this is worth repeating, that the COVID-19 pandemic has had a disproportionate impact on girls and women in all their intersectional identities that they bring, and in every aspect of their life, but particularly on their sexual reproductive health. It's worth repeating because it seems like the key decision makers and stakeholders don't hear that often enough or don't act on it. But it's not just the pandemic that has had the impact on, girls and women. It's the conservative forces that exist in the larger context that have been, continuously creating the inequalities that we see and impacting women and girls disproportionately. And it's important to remember that in the context of COVID-19 as we go along. One of the things I also heard from every speaker is the need to really, in all the efforts that we might do, whether they're programmatic or policy, or if they're from the private sector, we must center the perspectives of girls and women into our efforts. Bring in their experiences, bring in their perspective, bring in their ideas of what the solution is. The last thing, and we heard this very, very clear, not only from the young people who were involved in the panel, but from all the other experts too, that centering young people, their perspectives, their meaningfully engaging them, but also bringing them in as stakeholders and leaders in their own right, in order to really bring about the solutions for some of the biggest issues that we're facing, particularly those that are about disrupting, the existing conservative context that we really need to address as we try to change, bring about the change we want to see. And the last thing I'll ask is, first of all, thank all of you who've, listened to this amazing panel and to the findings of the research. And I urge you all, research is only as good as it's used. So I urge you all to take up the findings and the recommendations that have been put forward by the young people who were involved in the research, and to use it in all sorts of policy windows and all sorts of solutions, and to use the evidence in order to bring about the change we want to see. Thank you all for staying with us throughout this panel, and hope you have a great day, evening, night, depending on where you are in the world.